be used to actually produce weight loss as well. And also, if you don't have a DEXA scan, this is the best way to assess muscle mass. You can get a home device called Yuma Health Scale. It's almost like a scale that you step on, but gives you the estimates of your muscle mass. And a bigger problem that they're seeing while being on GLP-1s, fertility starts to be occurring to these women who are infertile because of their PCOS, for example. That's why I make sure contraception is part of your strategies when somebody's on GLP-1 if she's a female. And again, AR wearables, it's very hot topic there. And they're talking about now a smart fridge that can actually list down all the ingredients of the food that's inside that fridge. A smart stove that can talk to your smart fridge and actually suggest how to cook these food that's in the fridge. So the only thing that's not getting smart is probably us, because we're going to be dependent on these things and we're not going to be thinking at all. And one of the best part for me, they offered lunches. So free lunches for everyone. If you're a vegetarian, if you like meat, they have all the healthy options for you. And again, for next year, I think they're going to do it in San Diego. But overall, it's a 4 over 5 thumbs up for the event. Even my toes are up to make it 4. But I highly suggest. I know Dr. Bill was not happy with the online part of this, but when you are actually there in the event, if you're a very I guess avid fan of integrative medicine, this is definitely a right conference for you.
All right, thank you. All right, thanks a lot. Okay, that was kind of like that summary we did, Stefan, after AMMG in the car that day with the little video we did.
Yeah, that was fun. I think that's a good summary. And we should always do that.
It's a kind of a neat thing to at least summarize things. Okay, Dr. Tano, sorry we stepped on your toes.
Hey, Doc, if I may real quick. Hey, Dr. Nario, with the Homeopathic Association in Nevada, as far as I know, we're the last association in America. I know Arizona has a little bit of association going on with this. And I believe every single doctor here or physician assistant or nurse or whatever can sign up through America to help strengthen this homeopathic association. Is that true?
That is correct. Even though you're out of state or whatever, I mean, any degree, I mean, we can definitely discern that. But everybody can actually join the Nevada Homeopathic Board. The reason why they do that is because we board certify them. So that's definitely something that they can add to their credentialing and credibility to practice CAM medicine. So these are complementary alternative medicine practices. So yes, definitely you are correct. Everybody can join the cause, and we're only 3 states. It's going to be Arizona, Nevada, and Connecticut. So as we start these edicts or laws that are out there, we want other states to pattern themselves to have their own homeopathic boards as well. And that's why we're starting that little spark to make it bigger fire for everybody to follow through.
Amen. Thank you. Thank you.
Okay. All right, Dr. Tano, now go. Introduce yourself, because we've had Dr. Tano on a number of times before. He's an immunologist and an allergist and just a terrific speaker and a terrific educator. He's in the Minneapolis area, and pay attention because he's got the real goods. Okay. So go ahead, Dr. Tano. Sorry about the little delay there. And take all the time you need.
Dr. Tano, you're muted.
You're muted.
You unmute yourself.
You're muted, though. Unmute yourself.
No. Who muted him? I didn't mute him.
I didn't mute him.
I didn't. Oh, you're still muted, Dr. Tano.
You're muted. No, we can't hear you.
There.
There we go.
There you go.
There you are.
Thank you very much, Dr. Bill. Today, we're going to talk about prostatitis and prostate cancer. I'm sure that many of you have seen the surge of these conditions, not only in the US, but worldwide. So what is causing it, what behind it, and how do we actually diagnose prostatitis versus prostate cancer? it seems to me the two of them have similar things. And I wondered why or how can we really tear them apart? I have had several patients who have had elevated PSAs. And I was doing some experiments trying to treat them with antibiotics and antifungal, because I read somewhere that fungal infections can actually cause prostatitis. But many times when somebody presents with prostate problem, we think it's just bacteria or non-bacteria, and then we give them antibiotics or whatever else we give them. So today we're going to go step by step and try to focus on what may be the contributing factors and how we can approach it so then the patients can get relief, and also not put them through unnecessary testing such as biopsies and all these things that are not quite good. So that's what we're going to do today. I want to share my slide, if I can. Slideshow from the beginning.
We
So
see
do
the slides.
you all see my my slides?
Yes, we do.
Good to go.
Very good. Good to go. All right, so I said prostatitis versus prostate cancer. I'm trying to write a book, and I call it the same title, Differential Diagnosis and Treatment Protocol. So this is the book cover that I want to put on it. If you look at the cover, you can see that the prostate looks a little bit like the uterus, isn't it? Because embryologically, basically the prostate and the uterus come from the same origin. So whatever happened to female uterus can also happen to male prostate. Some references, I said that we should not, this is copyrighted because I'm putting in my book, and I don't want people to do anything with it. So I want to make sure that if you want to take some of it to reproduce all of it, I want you to ask me before you do so. I have two websites that we'll be able to talk about later when we turned off the CME. So introduction to the prostatitis and prostate cancer. So prostatitis and prostate cancer are two prevalent conditions affecting prostate gland in men. While prostatitis refers to the inflammation of the prostate, often due to infection, prostate cancer involves the malignant growth of cells within the prostate. So here are the definitions. Inflammation of the prostate gland can be bacterial or non-bacterial. Symptoms include pelvic pain, urinary tract, urinary difficulties, and sexual dysfunction. This part I cannot emphasize enough. A lot of times people have sexual dysfunction and they don't know that their prostate is a major issue. So they don't address that issue at all. But in our patient, if someone comes with sexual dysfunction, we should actually investigate the prostate highly to make sure that it's not the one contributing to the problem that they're experiencing. One of the other things, the reason I'm doing the presentation also is that we do talk a lot about female health. We talk about hormone replacements in females, we do a lot of stuff, but it looks to me that our presentations are quite skewed towards women's health than men's health. So we probably need to pay more attention to the men as well. The prostate cancer, malignant growth cells with prostate are often symptomatic in early stages, can metastasize to other parts of the body, and we know that. So what are the prevalence and the statistics of that? Prevalence affects, the prostatitis affects about 10% of the men at some point in their lives, and ages mostly 20 to 50, and chronic prostatitis prevalence estimated about 2 to 6% in general population. Geographic variation, higher prevalence in North America and Europe. Whereas the prostate cancer is more common in men over 50, and the prevalence is North America, Europe, and Australia. Can anybody guess why these countries or these continents have more problems than anywhere else for prostate cancer?
High fat diet.
High fat diet, Dr. Clearfield said. Anybody else? Why do you think we have more prevalent prostate cancer in North America, Europe, and Australia?
It's a lack of iodine.
Lack
and,
of iodine.
and vegetable oils.
Okay. Anybody else?
Chemical exposure.
Chemical exposure. That's a big one. Actually, I think we do have a lot of chemical exposure that may be driving this, and you will see as we go what is actually causing this plethora of prostate cancer worldwide. So mortality, prostate cancer is the 5th leading cause of cancer death in men. And this is the 2nd most prevalent cancer in men. So if you look at the cancer rankings, lung cancer is 1 and prostate cancer is number 2. Actually, I did not know that it was that high, but doing this studies and trying to figure out, definitely prostate cancer comes up very high in terms of prevalence. Colorectal cancer next, stomach cancer. It's the 4th most common cancer, higher. Why is stomach cancer more prevalent in Asia? Does anybody know?
Low stomach acid.
Probably low stomach acid, but
MSG.
I didn't hear that.
MSG.
Yeah, MSG. Okay, that is possible too. And where else do we find stomach cancer? Do you guys know? Besides Asia, I can tell you in Africa, in places like Mali, they have higher stomach cancer. And the problem is smoked fish. A lot of these people, they eat smoked fish. And because of that, they get stomach cancer more often than not. So it looks like lung cancer is due to a lot of smoke. Stomach cancer is due to smoke as well. So smoke is not a good thing for us. We should not put any smoke in our body at all. Liver cancer, as you can see, you can go down I put the 10 most common, and you can see all these cancers that are here, but prostate is 2nd in prevalence. Where do we find it most? It's very surprising to me that in 2020, there were about 1.4 million new cases of prostate cancer worldwide. And the highest incidence rates were observed in Guadeloupe and Martinique. Do you guys know what these are? The Guadeloupe and Martinique, where are they? Anybody?
I never heard of that.
Caribbean.
Okay, so they're in the Caribbean, and these are French territories, actually. They're French, it's like Puerto Rico is American. Guadeloupe and Martinique are actually French islands. They're French citizens there.
I'm guessing high carb diet.
No, actually, do you know? So what is the economy? Well, they grow bananas. And
right.
They grow bananas, and they use one major chemical for the banana growth. And that chemical is an organochlorine chemical. It's called capon or chlordecone. The chlordecone or capon is the one that is causing this prostate cancer in Guadeloupe and Martinique. And all the islands, actually, you will see that they have more in Barbados and Haiti and all of those places where they have the banana grove. So in Europe, it's Ireland that is also or has more prevalent, but that one was not quite clear to me, the reason for.
I've looked into that actually. They have one of the lowest concentrations of iodine in the urine by WHO testing.
The Ireland people, right?
Yeah, they have low iodine.
Iodine, yes. Okay.
I wonder if the halogens that are used on the bananas, they bind to the iodine binding sites of the prostate as well.
Oh, that is possible. That could be destruction of iodine or displacement of iodine that will be driving that. But it's one major finding that I was really surprised by. And the death rate is more common in Zimbabwe, Barbados, and Haiti. So even though it's more prevalent in the other Martinique and Guadeloupe and Ireland, but the people who die most are Barbados and Zimbabwe and Haiti. I hope everybody knows where Zimbabwe is, right? Because when we talk about Africa, a lot of people don't know. The prevalence of and mortality of prostate cancer varies significantly by region, influenced by factors such as access to healthcare. So even though it's prevalent in these small places, but in the US, Europe, and Australia, we have better diagnostic apparatus that allows us to pick it up early. And so when we pick it up early, people don't die. But if we wait until it's metastasized, then death rate increases. Unfortunately, the developing countries do not have the means to diagnose early. So by the time they find out, it's already too late. Survival rate, for instance, in developed countries, is about 97% to 98%, whereas for developing countries, it's way less. The time they find out it's metastasized, it's about 43%. So exposure to pesticides is a major issue. You can see the key point that I was talking about, the organochlorine chlordicone and the key point. Genetic factors, that one I'm not sure. It doesn't really look nice when I look at the different regions. It's about the African ancestry has the highest prevalence of prostate cancer. But when you look at regions in the US, for instance, where we have more concentration of African Americans, it doesn't appear that they have more prostate cancer than others. So I'm not sure what to make of that statistics, but that's something that we can sort out and see exactly why African Americans have more prevalence. The explanation, though, could be because of poverty and lifestyle choices that they make, and they're more exposed to chemicals. That would probably explain the reason why African American ancestry has high prevalence of prostate cancer. But if Africans had more, then if you look at Africa itself, we should have more prevalence, right? But it doesn't appear that those countries in Africa have more prostate cancer than anybody else. So again, looking at the statistics and trying to make sense of it, it doesn't seem to pan out. Environmental and lifestyle factors, certainly we hint into that. So I think that could be one of the major issues that we're facing. So the pesticides, we have a Kipon and the Caribbeans, but we have many other organochlorines like DDT. Even though DDT was abolished in 1972, DDT is still prevalent in the environment. So when you combine all the organochlorines together, probably they're exacting a lot of effect on the prostate cancer itself. Other pesticides used in agriculture could synergistically add to the organochlorines to cause the prostate cancer. Heavy metals such as cadmium, arsenic, lead, they also contribute to the prostate cancer. And then you have all the polycyclic aromatics, you have the PCBs, you have the particulate matter such as diesel fuel output, PM2.5 and PM10. All of those contribute to the prostate problems. Not only prostate cancer, but many other cancers that we see around may be also due to these chemicals. Volatile organic compounds, VOCs, they also contribute to the cancers. How do we get cancer in those regions? Contaminated drinking water. Now, all of us know that drinking water contamination is worldwide, right? And what is the one chemical that contaminates mostly, but is a major contaminant in drinking water that we know? Even recently, the government came to say that that's a big problem. What is it? Anybody? Does anybody know what chemical?
Is it glyphosate?
Not necessarily, but glyphosate is a good one, but there's a bigger problem that we find, and that one is a forever chemical. Do you guys know?
No.
PFAS.
Mhm.
Or the PFAS, are you guys aware of the PFAS? It's a fluoridated chemical. So they have several fluoride atoms attached to carbon, and that is almost indestructible. And it's everywhere. The water system, the aquifers, they're all contaminated by that. And that chemical plays a major, major role in many of the pathologies that we see around. So this is very, very important.
That's used as like what is that used in? What industrial products is that used in? How's it in the water?
Oh yeah, they use it in many industrial productions, and it goes into the water, and the runoffs go into all the water system, and that's what it is.
You have me thrown there because like, well, it can't be fluoride. The government loves putting fluoride in the water.
No,
But
it's a fluoridated perfluorocarbon. That's what it is. They call it.
yeah, they're both bad. Fluoride's no good. Any way you look at it, again, it's a halogen, and
the halogens displace other halogens like iodine.
It like iodine.
Yeah. Okay. We have the statistics, and you can see before. So how many of you know when PSA came into our diagnostic armamentarium? And who was the father of it? PSA.
Got me beat. Mm-hmm.
Anybody? No? So PSA actually was discovered by a person called Richard Eblin, and that was 1980. But it took a while for people to develop that as a test that would be acceptable. And they started to use it in the mid-1990s only. And that's how PSA became the diagnostic instrument. Before, we did the DRE, which is the rectal examination, digital rectal examination. And that one, if you use that alone, it would probably be 43% diagnostic possibilities. But if you use the PSA, you can account for more. Unfortunately, increasing PSA is not necessarily the only thing for prostate. It also affects the prostatitis. So when people have prostate inflammation, they can have an increased PSA. So how do you disentangle between the two? My concern is that in developing countries where they don't have all the means of detecting the prostate cancer, they may look at the increase in PSA and say, oh, you have prostate cancer. And then they're going to start treating with a chemotherapy, radiation, and all of that. Whereas perhaps these people need just an antibody or antifungal or whatever it is that is causing their prostate problem. So that's one of the major concerns I have, and the reason why I was trying to disentangle between the two conditions. So talk about any of these guys. I'm going to just skip some of that. So understanding prostatitis and prostate cancer, the Tobin framework. So everything I do now, I have come up with this acronym Tobin, and Tobin is, I would say Mr. Tobin. So it's like Tobin is the name of a person, isn't it? So Tobin is toxic overload, biologics, and biologics is hormonal imbalances, infections, and nutrient deficiencies. If we can account for these factors, then we can account for why we have the chronic diseases in our midst. So we can talk about the toxic overload. My go-to table that I use all the time in presentations, everything I do, is the CDC fourth report. For those of you who had the first two presentations that we did, you remember that the CDC fourth report that came in 2001 actually has a group of chemicals in our blood and urine that they're detecting since 2001. And the CDC finding these chemicals in the blood and urine of majority of people that they tested. They said that those chemicals don't do anything we don't know. Don't worry, don't panic yet. And every couple of years, they are amending the CDC fourth report, and the chemical list is lengthening. But the conclusion has always been, don't worry, don't panic yet. My question is, when are we going to worry? When are we going to panic? When everybody got cancer and died? Or when we have all these chronic disease, diabetes, blood pressure, cholesterol, and all these things that we treat day in, day out, that's when we're going to try to address it. No, even with this, we still say, well, don't worry, don't panic. So I went and looked at these chemicals in the CDC fourth report and found out that majority of them, actually a lot of them, cause thyroid disruption. So they kill the thyroid because the thyroid doesn't work. It's like your phthalates, your bisphenol A's, all of those are thyroid disruptors. Now, the major group of the chemicals that we have, though, are the estrogenic chemicals. All your PCBs, all your other major group of chemicals, thousands of them, they mimic estrogen. So that's why I said that we have an estrogen pandemic. Because they mimic estrogen, they cause other problems. And one of the major issues, they make the insulin go up. So when we have an increase in insulin, that causes people to crave sweets. Or if inadvertently they eat a lot of carbohydrates, then the blood sugars go up, and the insulin is the #1 fat maker. So what it does, it takes the excess glucose that we don't need and puts into fat cells. So it's a simple mechanism. As time goes by, we have more people being obese. And since the mid-1990s, when we brought glyphosate in our food chain, and glyphosate is one of the biggest estrogen compounds, you can see that obesity, for instance, has gone up tremendously, and the comorbidities that go along with obesity also have gone up tremendously. So we cannot disentangle the chemical components from the chronic diseases. We cannot say, oh, chronic diseases don't come from somewhere else. I really think majority of the chronic diseases that we see around come from the toxins that we have in our environment today. And the reason why 2.7 billion people will be obese by 2025 is because of those chemicals. Because now, before, when I was growing up in Africa, people used machetes. That's what they clear the fields with. Now, if you go to any village, they're using glyphosate, they're using Roundup. Well, that Roundup has the side effects, and people don't know about it. People drop dead. Nobody does an autopsy to figure out why they're dropping dead. That's because that they're using this chemical, and that chemical causes cancer, it causes all kinds of things that people are suing Monsanto left and right. You know that, so I'm not going to go further. But the reason I'm saying this, in terms of prostatitis and prostate cancer, these estrogenic compounds play a major role. They cause the prostate enlargement, they cause the prostate cancer, and also they cause the inflammation of the prostate as well. And that is a major finding that we can take home. So when we talk about prostatitis, prostate cancer, we should pay attention to the toxic overload. And then we have the biologics, which is hormonal imbalance. Obviously, when you have too much estrogen, you're going to have that. But if you have obesity, what does obesity produce? What the fat cells produce that can cause hormonal imbalance? Anybody? This is a review because with Dr. Halassa's group and everybody, we have beat that to the punch. We have beat it up too much.
What was the question?
The question is, when people get obese or they become obese, what type of chemicals do they produce that cause problems?
They produce more aromatase, and they
correct. They produce more aromatase, and the aromatase is going to do what?
They're going to get fatter.
It's going to convert the testosterone to be estrogens, right?
Yes.
So if you convert the testosterone to be estrogen, then you have even more estrogen problem. So when we see people who have obesity problem, we can readily close our eyes and say you got estrogen problems because you're converting your testosterone to estrogen, whether it's men or women. And again, when we have more estrogen, we have more prostate problem, we have more cancers, 7 different cancers in women. But for men, prostate, lung cancer for men who never smoked, and colon cancer. Those are major ones that come through.
Yeah.
So toxin overload, hormonal imbalance, and nutrient deficiencies. Nutrients such as zinc and vitamin D can be, if they're deficient, can contribute to prostate enlargement or prostatitis or prostate cancer and all of that. So those of you who do base functional medicine, how many of you recommend vitamin D to your male patients and say, hey, probably try as much, and how much do you use?
Yeah. The leaner they are, the less they need, but the fatter they are, the more vitamin D they need.
Correct. Many of the obese people, they have lack of vitamin D. So if you test majority of them, they will have low vitamin D. And how much do you have to give them on average? Does anybody know?
If the BMI is like 40, they probably need like 15,000 units a day at least.
Right. About 15,000, but on average, it's about 8,000 units a day for many people. Unfortunately, though, if you get 10,000 to 8,000 units a day to anyone, and so what is the range? This is another case. What is the range of vitamin D that we're shooting for?
We're shooting for between 80 and 100.
Oh, correct. So it goes from 30 nanogram per ml to 100 nanogram per ml when you look at many labs. Unfortunately, the general practitioners, most of them who are not into functional medicine, if they see a vitamin D level of probably 60, they're already screaming, oh, your vitamin D is too high, let's reduce it. Then they stop the vitamin D supplementation, which can be counterproductive for many of the patients. I really think that we have to educate more and more people to understand that if you are between 50 to 70, that is actually optimal. If you are 70 to 100, that is protective for the skin cancers, for prostate problems, and all of that. So you want to shoot for the higher end rather than the low end.
Yes.
So zinc is another element. What does zinc do? What is the role of zinc in men and women?
Zinc is aromatase inhibitor.
Zinc is definitely an aromatase inhibitor. So that's why zinc is important in those, if you have zinc deficiency, then you definitely need to replenish it. And for me, because I don't test that, I just make sure everybody takes zinc. And what is the dosing of zinc that is optimal? Anybody knows?
About 15 milligrams a day. I find any more people get sick to their stomach if they take it as a supplement.
Well, it depends on what zinc you're using. If you use some of the professional companies' zinc, you don't have any problem with it.
Yeah.
So normally it should be about 50 to 60 milligram a day.
Oh, it's a lot.
Yeah, in order for it to do the job as an aromatase inhibitor. They have to have a higher number.
Oh, true. Yeah.
So prostatitis, we're going to go through it quickly and see. I give you the ground for both prostatitis a little bit and prostate cancer. But there are some classification of it, and there are 4 different classification of prostatitis. We have a category 1, which is acute prostatitis. That's not common. It's bacterial, and many times we give antibiotics and it goes away. The chronic bacterial prostatitis, though, which is the category 2, is a common subtype that involves persistent bacterial infection and recurrent urinary tract infection and prostate pain. The most common is known as chronic prostatitis or chronic pelvic pain syndrome, CP or CPPS, category 3, and this is the most common form, which may be associated with underlying infection process, and we can subdivide it into 2, the 3A and 3B. One is inflammatory, the other one is non-inflammatory. And also a symptomatic inflammation of the prostate, which is the category 4. So people can have that and they will never know. Can anybody tell me one bacterium that may cause an asymptomatic prostatitis? Anybody?
Man, I knew this one. Yeah.
A lot of times when people have chlamydia, they have no idea. Men, for instance, they go for infertility testing, and during the infertility testing, all of a sudden they found out that they have chlamydia. And how do we detect chlamydia these days? When you send them for a test, what do you do? What type of testing do we do? Anybody?
You can do a urine sample or a urethral swab.
Those may not pick it up because chlamydia trachomatis is what type of bacterium? Where does it live?
It lives in the urethra.
But where exactly in the urethra it is? Anybody?
It's an intracellular organism.
Correct. It's an intracellular organism. So if it's in the cell, it may be very difficult to pick it up, isn't it? So but we must do something else to try to pick it up. And what test? Yes.
It can be picked up in the urine. The problem with the urine collection is the way that it's collected is not correct. The way it's supposed to be collected, the patient cannot urinate for 1 hour before the collection, and
Right.
they only need to put in the vial maybe 5 to 10 mLs.
You may,
That's
okay.
the
Yeah.
amount of urine that they need. But most of the time they don't get instructed. Sometimes they get instructed to do a clean catch,
Yeah,
which you lose the chlamydia in the toilet.
Yeah.
that's
So
correct. And
that's one of the problems. They're just not instructed with a proper collection.
correct. But there's
With the
another
urine.
test that they do mostly, which is more common. So if you ask for chlamydia test, they're going to do that. What test? They do a PCR on them, a polymerase chain reaction, to find out about the chlamydia DNA. And that is a major test to detect chlamydia these days. So epidemiology of that, we talked about it. So the PSA definitely, so what is the PSA? Anybody knows? And what does it do? Anyone? PSA? All right, so the PSA is just a protein enzyme, and the role is to liquefy semen, basically. And so if it seeps into the blood because of disruption of the prostate, then we can use it as a biomarker. And that's how it works. So the PSA definitely is an enzyme, protein enzyme, that is supposed to help semen be fluid. Now, when it comes to exposure, bacteria and other things that cause prostate problem, we have the chronic bacterial prostatitis and candida prostatitis. How many of you think of candida when people present with prostatitis or prostate problems. A lot of people don't, but this is very, very significant because I found out that once the prostate gets colonized by Candida, then it's very difficult to treat. And how does the Candida get into the prostate to begin with? Well, most of the time, people present with the acute forms and stuff, we start giving them antibiotics. And we end up killing the good bacteria that are in the prostate, and then the bad one proliferates, and one of them is Candida. So Candida prostatitis is a big, big problem, and sometimes it's difficult to treat. How do we know, or how can we differentiate Candida prostatitis versus bacteria prostatitis? That's a big one. And most of the time, the bacteria, definitely you can see that E. coli is about 80% in the cases, but you have other bacteria such as Proteus, Klebsiella, Pseudomonas. These are opportunistic infectious agents. They come and infect the prostate. They cause more problems. When we treat, most of the time we gear our treatment towards E. coli, and that's why we're having some resistance to those bugs. There's other bacteria involved that we don't really pay attention to those. So when we have killed the good prostate bacteria, then the bad one proliferates. One of them is Candida. So how many Candida groups do we have? Does anybody know? What are the different kinds of Candida? Anybody? Any takers? Dr. Stephen?
I mean,
You left me dry.
Candida albicans.
Albicans is a big one, but
Yeah.
what other Candidas do we have? Anybody?
Candida cruzi,
Okay, that's a good
Glabrata.
one. Candida cruzi, and what else?
Glabrata tropicalis.
Candida glabrata, Candida tropicalis, and what other Candida do we have?
That's all the candidas I can remember.
Candida praesilosis, and we have a new one. Actually, that was discovered in 1994 back in Japan. It's called Candida auris, and that Candida is multi-drug resistant, and they're finding in the hospitals these days. So all of these Candida groups can cause prostatitis. So if you think of Candida albicans only, and you're trying to treat, so what treatment do we give for Candida albicans?
You can do diflucan, that's usually commonly used, or
Yes.
they use nystatin for that.
Well, nystatin is really weak. So diflucan is actually the best treatment for Candida albicans. So how do you treat? How do you what do you use? I mean, what is the dosing for nystatin to treat Candida albicans? Does anybody know, especially when it comes to prostatitis?
I usually use it topically, nystatin. That's the only formulations I'm familiar with for nystatin.
Yeah.
What about ozone? Wouldn't ozone work?
Yeah, it may
for all of
work,
this?
but it may work, but in all the treatment, nobody talks about ozone.
I know. I don't understand why. I was hoping you could
Yeah,
illuminate me.
probably would work if you can get into the prostate with it. But I
Well,
really
there's a really direct route through the urethra.
right, yes. So that's a good thought. So I think we could probably see if we can try that, it would work.
Who's
But
doing
if-
that?
Go ahead.
Anyone doing that? I've never heard of that before.
I never heard anybody doing it, but I don't know. I think it's a good idea, but I have not seen anybody do it.
I'm using high doses of iodine for bad fungal infections. I think it would work the same for this.
Okay, that's possible too, because I'm not sure. I have never used that, but I use diflucan, and I use probably 100 milligram a day for about 20 days or so, because for the prostate infection, you have to use it on a longer course, otherwise it doesn't work. So then after
You can use Matlin Blue photodynamic therapy. Just drink a lot of Matlin Blue and shine a light suprapubic, red light, and you may get some of them out.
Okay, so that is a possibility. I think I've never done that. Have you tried that, Dr. Alassa?
I did it for cystites,
Cystitis,
and
okay.
it works very well. For prostatitis, yeah, you can say cystites and prostatitis, sometimes they get together.
Right.
I think it would be good because they concentrate the methylene blue in the urine, and you get very nice stain there. But there's lots of cases where they fail antibiotics.
Right.
And they be successful with methylene blue, especially adding cyclodextrin, because now all the antifungal drugs, if you look at it, the one that's coming out recently, they all compound with cyclodextrin. So that's the movement that we can teach our doctors to compound all the injectables with cyclodextrins.
Okay. Yeah, so I mean, all of these are new treatments that people did not have before. So at least incorporating these in the treatment, perhaps we get better results. For me, I've used antibiotics. So when people come and they have prostatitis, I think of bacteria. If I think of chlamydia, what antibiotics would be necessary for eradication of chlamydia on a longer course? Anybody?
Zithromycin was the old one, but you can use doxycycline as well.
Yeah, both actually, doxycycline and azithromycin. So for me, to get a quicker result, I mix both of them, give them probiotics as well, and prebiotics and digestive enzymes, because as you will see, when the gut bacteria is dead from antibiotics, and we have all the bad proliferation, then people get IBS kind of symptoms. If they have IBS, what I have found out is that most people who have prostatitis, actually they have IBS in conjunction. So the two of them coexist. So in order for us to treat the prostatitis, it is imperative that we also treat the gut. And to do so, I give them probiotics, prebiotics, and digestive enzymes. Then that will help tremendously with the gut.
Apparently there's some efficacy using also biocidin for prostatitis for acute and chronic treatment. You can do for chronic rectal suppository and the biocidin LSF and then the GI detox.
Right. So that's interesting, because at one time I had a patient who had like a PSA of 15. And I started this therapy on him. I gave him doxycycline, azithromycin, diflucan, and the PSA dropped to 7. So I said, whoa, definitely we have found what the culprit were. And then it started climbing. After his course, he started climbing again. I said, why don't we do a compounded diflucan where he can use it as a suppository? And when he did that, actually, it didn't really make a big difference. But if a biocidin would do, I wouldn't mind trying that and see if that would make a big difference in some of the patients that we have for prostatitis. Anybody else has used it?
No, but I've had 2 interesting cases recently. I have treated E. coli, which was confirmed in the urine culture. I treated this successfully with 50 milligrams of iodoral for 10 days. And I was able to then repeat it in another one that was just symptomatic. We didn't do the testing. It also improved. I've also been able to treat toenail fungus with 50 milligrams of iodoral for 6 months. Fungus takes much longer to treat than the bacterias.
Okay, so what is the best? So now that you bring in the toenail fungus treatment, I'm going to quickly give you one thing. What is the best treatment for toenail fungus that will use some sort of iodine?
Orally and also topically.
Yeah, topically. What sort of iodine is
2% or higher Lugol's iodine.
Yeah, potassium iodide actually works best.
Yes.
So if you use potassium iodide, you can eradicate a lot of the toenail fungus that people have.
Yeah.
Bacterial and fungal contribution, we have that. I give you a lot of, I talked to you about the chlamydia, persistent with chlamydia, etc. The test, you see the test, the nucleic acid amplification test, which is a PCR basically to find the DNA of the chlamydia. That's what we talked about. Antibiotic treatment, we talked about that, and we go in. Differential diagnosis for Candida, we have a glabrata. We have Candida glabrata is a really difficult Candida to treat. But most of the time, how many of you think that Candida could be contagious, except for not only Candida auris, but other Candida that can be contagious? Anybody?
Maybe to those who are immunosuppressed, low iodine. Yes, of course.
Yes, actually, Candida can be contagious.
Yeah.
When you look at husband and wife, if you have one of them has thrush, you may want to look at the other person too and see in the mouth if they have any problem. Recently, I had a lady who I hadn't seen since 2017, and she was looking for me everywhere. She said, "Oh, I found you. I haven't come back to see you, but I have this Candida that I have been going on for a year, and I don't know what to do. My OBGYN keeps on giving me some topicals, and it's not working. Every time I get my period, it flares up, and I get so itchy, and I cannot do it anymore. So can you help me?" I said, "Sure." So I give her my concoction of diflucan, and oh, the other thing that we can do, what kind of supplements can we give for people who have Candida infections? Anybody?
Iodine.
Iodine, what else? What other supplements work good?
Boric acid.
Boric acid, so that one was using boric acid, but it didn't help her any, but it's good idea.
Oregano oil?
Oregano works good. What other supplements can we use?
Especially for people who can't tolerate the other things that you've been mentioning, like me.
Yeah, so caprylic acid is a good one. So you may want to give them some caprylic acid, and there's a supplement called Candisol that is also very good. So I combine all those, Candisol, caprylic acid. I just hit her with all the major ones that I can see, plus the diflucan, and I have her do it for like a whole month.
What about CLA?
Well, you can do that, but it's not one of the major treatments, but actually it probably would work in conjunction with all the other stuff. So definitely caprylic acid, Candisol, heal the gut, probiotics, prebiotics, digestive enzymes, give them some diflucan, but beware because gallbladder, for instance, is resistant to diflucan. So if it doesn't work, you will have to do something else. What other antifungal azoles that you can use if fluconazole doesn't work?
Itraconazole.
Yeah, itraconazole would do good, or voriconazole would do good. So you have some other choices that you can do. If it gets worse, what else can you use? Any other antifungals that we can use?
How about Saccharomyces boulardii?
Yeah, that's a probiotic. You can use that.
You use voriconazole?
Yeah, voriconazole, I said that. You can use that. What else?
Amphotericin.
Amphotericin B, that would do good as well. So the casfogens, you can do that too. So there's a lot of other things.
Amphotericin B is the most toxic to the liver. They're supposed to take it out.
Exactly. Amphotericin B is the most toxic. That's why it's not your first line of choice. But if you have really a severe Candida, like Candida auris, that is a multi-drug resistant, and you have no other choice, then you have to go by even if the toxic is better than nothing, and that's what you would use those kind of more complicated, more strong antifungals. So we talked about all these different kind of Candida, the Candida tropicalis. Candida glabrata, Candida parasilosis, Candida krusei, and then there'll be a multi-drug resistant one, Candida aureus. Any questions at this point? Anybody? So underlying cause that may be contributing to all of these, for instance, for the Candida overgrowth, diabetes. So why diabetes will promote Candida overgrowth? Anybody?
It eats a sugar.
Because they eat sugar. Candida loves sugar. And so if someone has diabetes, then certainly they have all the ingredients to make sugar. Now, if the sugar is available, then the Candida is going to proliferate because we're feeding it. What about bacteria overgrowth?
Same.
Same thing. The bacteria, in order to replicate, they need glucose.
Yeah.
And who has more glucose than diabetics? Not a lot. Who have all the diabetics, they have tons of glucose around. So they're going to have more drug-resistant kind of bacteria that will grow. And as you notice, since the mid-1990s, we have a lot of multi-drug resistant bacteria. One of the bacterium that affects the prostate is also Enterococcus. And if you look at hospitals and stuff, they do have a lot of Enterococcus infection. That is a major, major problem, major issue. Many people, and those are most of the time drug resistant. So you have to figure out how to treat this Enterococcus and get rid of it. If you have MRSA, what would be your best choice for MRSA treatment?
Bactrim.
MRSA, Bactrim will not do that. It will not help.
Metronidazole?
But yeah, metronidazole can do, but it may not be first line.
Clindamycin.
Not the first line.
Vancomycin?
Vancomycin is going to be your first line.
That's
But
IV though.
can you do vancomycin PO?
No.
If you do vancomycin PO, it's not going to work. That means you have to put a line in these patients, a PICC line or anything to give them IV vancomycin.
No.
So if you're infusing the vancomycin very fast, what syndrome do they get?
They can get the E. coli dies and it releases the endotoxins, and they can feel very sick from this.
Yes, and how do they become calorized? They call it somebody syndrome.
Red man syndrome.
The red man syndrome. So they can, if you give them vancomycin and you infuse it very fast, they can get the red man syndrome. So you have to be aware of it. What other PO medication that would be equally potent as vancomycin that we can give to people who have MRSA infections?
Is linezolid?
Linezolid. Well, linezolid. What is the dosing of that?
It's been a while. I don't know.
Yeah. So I'm just reminding you because I know we all use functional medicine things, but sometimes you're going to need those drugs. Yes.
I'm going to mute Halasa.
Yeah.
I'm not host. Okay.
So linezolid, the dosing is 600 milligrams twice a day. Yeah. So if you find someone with MRSA, either you do the vancomycin IV or you do the PO linezolid, and that may be good enough. So if they develop C. difficile, then you're going to have to give them what?
Metronidazole.
Metronidazole. Then you give them metronidazole. Correct. Pain management, NSAIDs and stuff, alpha blockers, you can give to them. Stress reduction, you have to make sure that you do mindfulness and all of these other things that we can give nutritional. So when people have prostatitis, and we're thinking that some of it may be due to environmental toxins, and we have said that the environmental toxins that are very prevalent are going to be the estrogenic chemicals. So what type of nutritional recommendation are you going to give them? Anybody?
They want to avoid oxalates.
Okay, we can avoid oxalates. What else they can do? What nutritional recommendation will you give them? If estrogen is the problem,
then they need to avoid the soy.
they have to avoid soy. Anything else they should be avoiding?
The seed oils, they're full of halides.
Phytoestrogens, estrogens.
They have to avoid the phytoestrogens, anything that is xenoestrogen, right? And so what are the common food that we eat that are full of xenoestrogens, and they can cause tons of problems for everybody?
Chicken.
Chicken, that's a good one. If it's not organic, yes, certainly. Chicken could be a big problem. What else?
Corn and wheat.
Corn and wheat, absolutely. So what is wrong with the wheat? What is the problem? Why wheat is so bad?
What isn't wrong with it?
Anybody?
The glyphosate.
The wheat is so bad because of glyphosate, right? But so can you explain to me why glyphosate intervenes wheat? Because it's not genetically modified.
No, the glyphosate, it destroys the gap junctions in the intestinal
Yeah,
lining.
I understand that. But the wheat, why glyphosate and wheat? What is the problem with that?
They spray it for the pesticide.
We are spray. So when do they spray it? So anybody, do you know?
Oh yeah, they spray it so it's easier to harvest.
Correct. So, okay. The people in the Midwest where we are, in Minnesota, Dakotas, Iowa, and all of that, they have a big problem. One of the problems they have is a fungus. And the fungus is known as Fusarium. How many of you know of Fusarium?
Yep.
Yeah. What does Fusarium produce? Anybody knows what Fusarium produce?
Alpha fetoprotein, whatever. No.
It produces
alpha something.
Yeah, it produces zearalenone.
Oh.
And zearalenone is an estrogenic product. Actually, the farmers use it to fatten up pigs. So if they leave the corn or the wheat on the farm too long and it rains on it, that fusarium grows in it, and the farmers have to pay more money to clean it up. So when the wheat is a little bit greenish golden, they want to harvest it. Unfortunately, if they use their combine, that green is going to tangle into it, and they're not going to be able to harvest it fast. So one of the guys got smart and said, hey, why don't we dry it up with Roundup? So they start spraying Roundup on the wheat and dry it up. And it was easier for them to combine. So from that time on, since the mid-1990s, they have been doing this practice. Every time they're going to harvest wheat, they spray Roundup on it. Now they do that to 70 different crops or more. Before they harvest them, they spray Roundup on it. They call it pre-harvest Roundup spray. And since they start doing that, that's when we start having this gluten sensitivity, because before, everybody ate bread. There was no problem with the bread. Now that they're doing the pre-harvest Roundup spray, now you cannot tolerate bread. You eat bread, you get bloated, cramping, constipation, diarrhea, headaches, mood swings. So I have gluten sensitivity. Same people, they go to Europe, they eat bread there, they have no problem. They come back here at the airport, they eat bread, they get bloated. So I think that's what is causing the problem. But not only that, if they have fusarium producing zearalenone that is then affecting the wheat, if you eat that, again, you're going to get estrogen overload. And that estrogen overload is going to cause you to have inflammation, cancer, and all of these other things that we're talking about. So definitely wheat is not one of the best foods to eat these days. Now, that's why some people, they're talking about the icon wheat and organic wheat and stuff like that. I personally say, forget about the whole wheat. I just stay away from it. So what else are we staying away from? So no soy, no wheat. What else?
Well, corn.
Corn, absolutely, corn. Why corn is such a bad food? Anybody?
Hyperglycemic.
Yeah, good. It has corn has what? What does it have?
It has a fungus many times.
It could have a fungus, the same guy. What else does it have? What else corn is? In the United States of America, corn is a
Seed.
GMO.
GMO. It's a genetically modified to tolerate tons of Roundup. That's actually the #1 product.
There is something that's called aflatoxin.
Aflatoxin.
Aflatoxin, yeah. Is that
Yeah,
part of the contamination, or we got rid from that?
Well, aflatoxin is actually mostly in peanuts. So that is where you find it most.
Yeah. Doctor, this is Dr. Klotz. Just one quick question, please.
Yes.
If you would allow. You know, this is all very it's a very good presentation. Thank you. It's all very good information, and I'm happy to be listening to you. But what strikes me and what makes me uncomfortable, being one of those poor people who has bloat after I eat anything these days, is just that it seems like everything is corrupted. And I mean, what is left to eat that is safe? Beans are a problem, corn is a problem, rice is a problem, white rice especially, because some of it may be even plastic.
Right.
I mean, what is left? You can't eat chicken.
You can eat chicken if it's organic.
Not really.
Yeah, and how do you know it's organic? They lie. And you know, the beef and even the beef and the lamb and even the fish are now being injected with vaccines. So what does that leave us to? I mean, you know, maybe we should learn to be breatharians and just live on, you know, on the sun and the air.
Yeah, well, yeah, okay. So that's a good question, because we get this all the time. When you start telling the patients what not to eat, they say, well, what can I eat now? Because a lot of times people don't venture into some other foods that they can eat. For instance, I found out that African yams, how many of you are familiar with African yams?
They don't have it at my 7-Eleven, so I'm
They don't, yeah, exactly. But I'm just saying, for instance, in big cities like Minneapolis, New York, all of those places, you can find big, giant African yams. If you don't know, just check it out on Google. Those yams, actually, that's where we derive progesterone from. When they say progesterone is bioidentical, progesterone is a yam extract, those are the yam that give it to you. And they have low glycemic index. Most of the time, they don't grow them with pesticides or anything like that. So if you eat, they like potatoes, and they taste better than potatoes. If you fry them, you bake them, you cook them, they really taste good. And you can substitute potatoes with that, but many people are not aware of it. So it may be a good idea to instruct some of the people who cannot tolerate certain foods to look other things, other ethnic stuff, and choose some of these foods and eat. The other thing that I can say, you have all the vegetables, right? If they're organic, you can do that. Meat even, for instance, you go to the market, I call it market intelligence. When you want to buy beef, it has just beef, which we know they finish it with corn. So if we don't want corn, you're not going to buy that type of beef. The second one is grass-fed. The grass, they spray it. And then what is left is grass-fed organic beef. So now you find grass-fed organic beef. That, I suppose, is okay. But unfortunately, if it says organic on it, how many of you know how much percent is organic when we say organic?
Say that again.
How much percent is organic if it just says organic? Any product that says just organic on it. What is the percentage organic? 2/3. That means they're allowed to use some chemicals even in the organic production. When it says USDA 100% organic, that you can probably guarantee that it's organic. So that's why they make the difference between organic and USDA organic. So for me, I look at for USDA organic. Of course, obviously, all of you will know the Dirty Dozen. There's no dirty dozen, by the way. So the environmental working group is putting out the dirty dozen foods. There's no such thing because peanut did not make the list, and peanut is dirtier. A peanut is grown down south, and down south they grow cotton. And cotton requires 3 times more pesticide than any crop in the nation. Unfortunately, what the farmers do, they rotate the cotton and peanut. So 1 year cotton, 1 year peanut, 1 year cotton. So as the pesticide load in the ground is growing, so the peanut allergy. Now you have many of the kids who have peanut allergy. For that reason, they cannot take peanut to schools anymore. And that's where it comes from. So the pesticides is killing us. As the gentleman said, the pesticides are killing us. What do we do now? What do we eat? But for me, if we have prostate problem, prostate cancer, cancer problem, and we know that many of those cancers are due to the environmental toxins, perhaps the advice would be to avoid those estrogenic food for the prostate, so then the prostate cancer doesn't take over. If somebody has breast cancer, well, same thing. Uterine cancer or the female cancer that feed on estrogen, we have the obligation to tell them not to eat those foods because they're going to make it worse. Unfortunately, the oncologists, when they do the treatments, they don't advise their patients to what not to do, what not to eat, what chemicals they should not use. For instance, parabens, fragrance, mineral oils, petroleum, and all the beauty products that contain estrogen, nobody is advising them about that. But for food, for me, it's big because if you do corn, corn is used to fatten up beef, right? If we use corn to fatten up beef, and we have tons of corn syrup in our environment, sodas and candies and juices and all of that, plus we have the corn itself that we're eating, then how can we control obesity? There's no way. How can you control glucose proliferation that make candida grow? Maybe we cannot control that. So that's why it's good not to do corn. We have to stay away from the corn products. Now, if you're not doing corn, why would you do dairy?
Right.
Because the dairy, while we're feeding the cows corn, and the corn being #1 GMO, is contaminating the dairy. So I said, don't do the dairy, baby, because if you do that, you're not going to do so hard. Again, I talk about market intelligence. If a cow's milk is really good for us, it has protein, it has calcium, vitamin D, and all the things that the Dairy Association claims it does, Wisconsin alone can feed the whole world with dairy, right? So why would anybody in their right mind go and make almond milk, cashew milk, coconut milk, pea milk, soy milk, oat milk, and all of those milk that do not taste like milk? Well, what the market is signaling is that, hey, guys, I cannot tell you that, I cannot put a banner, say, hey, cow's milk is bad, but I can just guide you to choose something else. So that's what the market is signaling. So every time you see a food or a product with many, many substitutes, it could mean that the original product may not be so good. And that's what the market is signaling. So you have to always pay attention to that. So we're not going to do gluten. We're not going to do soy. We're not going to do corn. We're not going to do dairy. And above all, if we're talking about candida, what else are we not going to do? Anybody?
Sugar.
Sugar. So what do we use to produce sugar with? What do we make sugar with in the US?
Everything?
No, what do we use to create sugar? What is sugar?
Oh, what is used?
Anybody?
Honey.
Usually like
Sugar from the can, right? Sugar can.
Which one? Sugar cane, you said?
Sugar cane.
And beets.
No, that's yeah, sugar beets is the #1 ingredient.
Yeah,
beets.
full of all those things that you just talked about.
Exactly, and sugar beets actually was the #1 GMO. Do you guys know that? That's what Monsanto created first as a genetically modified food organism. So if you do,
what about monk fruit? I do a lot of monk fruit.
That's
sugar.
okay. You can do monk fruit. That will be fine. But if you're doing sugar, that's why you go to the market. If you look on the shelf, it says sugar. Then you have cane sugar. Then you have cane sugar organic. So they give you all these different varieties, and you have to pay attention. You have to look to see which one will be right. If it says sugar, forget it. Don't go even near. If it says organic sugar, you have to know if it's USDA organic or not. And if it says cane sugar organic USDA, you may be quite sure that is organic. And a lot of time they import that from the Caribbean also. And so if they're using all the chlordecone, all these other things that cause prostate cancer, all these cancers, and remember, if that causes prostate cancer, it could cause female cancers as well. So we're not really talking about the female cancers, but all the things, the estrogen that cause the cancer in men will cause the same cancer in women.
Sugar also feeds almost every known disease.
That's correct. And sugar will feed the bug, the resistant bug. So definitely don't do the sugar. That's why we should enlighten our patient not to use the sugar at all. It's not only the candida. So in the prostate, any questions? I think in terms of things not to do when you have prostatitis and things that we should advise our patient, it's quite clear what we should not do in many ways. Avoid those kind of foods. There are more to it than that I just summarized to these 5 major groups, not to do them at all. Inflammation mechanism specific to the prostate. We do have the prostate environment. And by the way, how many of you have heard of the prostate microbiome? Just like
you alluded to it at the beginning, right?
Yes, just like we have the gut microbiome, we do have the prostate microbiome as well. And there's a bunch of chemicals in there that we need to know. So when we have inflammation of the prostate, of course, you're going to have all your white blood cells that will come in there, and they're going to do their job. And so you're going to have inflammatory cytokines that will be produced, IL-1, IL-6, TNF-alpha. And we know that these are inflammatory cytokines. They're going to exacerbate the inflammation. So it's very important to realize that. Also, you have the oxidative stress things that will come in and cause more problems to exacerbate the inflammation as well. Prostate secretion. Now, how many of you, besides doing urine tests and doing all these other PCRs and stuff, do the milking of the prostate? How do we milk the prostate anyway? When I say milking the prostate, means that the prostate secretion. How do you get a prostate secretion?
Something not good to do.
Something not good to do. So, but if you want to get the prostate secretion, how do you get the secretion?
Press on the prostate.
Exactly. So you do a
rectal exam.
Exactly. You do the digital rectal exam and you press on the prostate and the fluid will come out. So then that you have to collect that fluid.
Well, ejaculation will come up. No.
Ejaculate, not quite. No. So what you get is the prostate secretion. It's a more, it's clearer.
Milking the prostate therapeutic? Is milking the prostate advisable as a preventive therapeutic?
No.
Like no.
No.
Okay.
I had heard for diagnostic purposes only.
So there's no advantage and there's no protection against prostatic disease by doing a prostatic milking.
No, not that I know of. I don't know. I don't think there's any advantage of doing that.
Where's your practice, doctor?
The only advantage is to be able to diagnose better, because urine is not necessarily the best diagnosis for prostatitis,
Right.
but the liquid from the prostate itself might be.
Where's your practice located?
Minneapolis, Edina.
Okay, in Minneapolis, where?
Edina, Minnesota. So
Oh,
Edina
Edina.
is a suburb of Minneapolis.
Okay, thank you.
Sure.
Super information. Thank you.
Yes. So prostatic secretion, you have a pH also that may be, so inflammatory mediators, we talk about that, and basically pH, if the pH is, you can think is acidic, and that would cause more problems in terms of antibiotic absorption. So in essence, the prostate is doing things. Also, there's some IL-8 that can be produced. What is the role of IL-8, interleukin-8? Anyone?
Interleukin-8, I think it's part of TH17 and interleukin-6. They work together.
So the interleukin-8 is going to be attractant to the neutrophils. So when the
right, same like interleukin-6, they both increase same time.
They would increase, yeah, they would attract the big eaters and small eaters, the neutrophils. So when they come in there, they're going to cause more damage. Also, when we have chronic inflammation, well, then the prostate environment is going to change. We're going to get fibrosis, and we will get calcification as well. Those destroy the prostate tissue and then tend to cause more problems as time goes by with those inflammations. So these are some of the things we need to keep in mind. Diagnostic challenges. So using the PSA, I said you could find PSA elevation in both prostate cancer and prostatitis. So is there any other way we can diagnose better? And that's where the MRI comes in. You can do the ultrasound, but the ultrasound may not be the perfect choice, but the MRI would be a better choice to figure out whether we have abscesses in the prostate and other kind of inflammatory things in the prostate. You can pick it up by using the MRI. And antibodies. So when we have cells go into the prostate, definitely they will produce antibodies. So they call it autoimmune response to a neurogenic inflammation. So autoimmune response, just like we have the thyroid antibodies, we can have the antibodies that also go to the prostate because the cells that go there, the B cells, are stimulated by the Th cells, Th1, Th2, they can produce these antibodies, and those antibodies can be really toxic to the prostate. Hormonal regulations, we talked about that already. Androgens, estrogens causing problems, so we're not going to beat it anymore. And microbial persistence and chronic prostatitis, we know the microbial resistance. One of the mechanisms of resistance is biofilms. Now, the biofilms is not only bacteria, but also for candida, for the yeast. They cause biofilms, and that's why it's difficult to treat them sometimes. When they have these biofilms, then the community is growing and they're protecting themselves, so we cannot get all those chemicals we use to kill them into the cells and kill them. So that's why this is complicated. Genetic environment, everybody talks about genetic polymorphism and all of these things. These are looking at toll-like receptors and how they intervene. We can check about that. I'm not going to go through that. The impact of chronic inflammation prostate stuff, we damage the fibrosis. We have a neuroendocrine response, neurotransmitters coming in, causing more problems. So it's a lot of information about what causes all these and future duration research and clinical decision making. What are we going to do? So actually diagnosis is very important. Most of the time we don't have a diagnosis. We don't know whether it's bacterial or fungal, and we start doing antibiotics that cause more problems. So it's important to, first of all, diagnose it better. Misdiagnosis is the problem. Moreover, distinguish chronic prostatitis from cancer is also crucial. When I set out to do the presentation, I said one of the major reasons I'm interested in this is that for developing countries, it may be very difficult for them to do, because they don't have the means of diagnosis. So they can look at the PSA when it's very high. They say, well, you got prostate cancer. And then they're going to do all the treatments based on that. And that may be the wrong decision, because this person may have just prostatitis rather than prostate cancer. So it's important to disentangle those. But in the developed countries where we have the means, we can use the multi-parametric MRI, and that will give us a better, clear image or clear understanding of what is causing the prostate problem. Diagnostic challenge of complexity, so we have those things. Role of bacteria, we got that. And the relationship between prostatitis and irritable bowel syndrome, I talked to you about that. And some people talk about fecal microbiota transplantation. I personally have never used this. Has anybody ever used this in any condition, whether it's IBS or it's difficult to treat GI problems using fecal transplant? Anybody? No, stay away from that, I think. So the multiparametric MRI that I was talking about, biomolecular techniques, PCRs, we talked about that a little bit, current and emergent therapies. There are many other things people are talking about. They're trying to figure out immunotherapy, different way of treating it, so then we don't have all these bacterial resistance that will go through it. And I'm going to go in through cases. Any questions before we do some cases?
Yes, what do you say about the ADC signal that is referenced in a MP MRI? Is that relevant, or
yeah,
you know?
The MP MRI is the multiparametric MRI, which is more detailed MRI than the regular one, and that's the one that would pick up most of the problem with the prostate.
Well, they mentioned the ADC signal as part of the report.
I don't see. Yeah, well, definitely. I mean, there should be some ways of reading it. Radiologists, once they do the MP MRI, they should be able to clearly tell us exactly what is going on with those prostate with problems, basic imaging. I didn't see the ADC MRI. What is that?
By the way, I put the name of the company, the Microgen DX test will tell you which microbes are infecting the prostate.
Okay. I've never used them, but that would be good to know, though.
And it's a relatively inexpensive test.
Right.
Well, we will try to refrain from mentioning any company names.
Exactly.
Yeah. Oh, sorry.
Yeah, because there's the
granting to me here. I do have some technical provider, but the provider CME, they have IT problems, but eventually we'll provide you with the link for this beautiful, great lecture.
Right. So case study scenarios for chapter this thing here. So advanced chronic bacterial prostatitis. Actually, many of you can just read it. I just gave you a lot of information based to give you all the things that you need to know. So 60-year-old male, long time sufferer of a urinary tract infection, presents with persistent lower urinary tract symptoms, including pain during urination, pelvic pain, and occasional episodes of hematuria. That sounds like prostatitis, right? So his medical history is significant for recurrent bacterial prostatitis treated with multiple courses of antibiotics. So what do you think right away when he has been treated with multiple courses of antibiotics and now this is still persistent?
Yeast,
Candida. So that is one of the major reasons for this. The second case is the complex chronic prostatitis and the pelvic pain one and neuromuscular involvement. So 40-year-old male reports non-relieving pelvic pain, urinary urgency, and painful ejaculation for over a year. Physical examination reveals trigger points in the pelvic floor muscle, and his symptoms do not respond to conventional pain relievers. So what is this? When they have painful ejaculation, we should suspect. Anybody without reading the whole case? I said it in the beginning, prostatitis due to
chlamydia.
Candida. Think of Candida yeast when they have painful ejaculation. So this could be one of your differentials when the patient can say, well, when I ejaculate, it's really painful. That's probably they have this Candida overgrowth. Treatment-resistant Candida prostatitis. So 65-year-old immunocompromised. When you hear immunocompromised, you know that it's already. Anybody? When we hear immunocompromised, what are we thinking of? Candida, yeast. So that's where they get it. Antibiotic resistant used for urinary tract infection present with chronic prostatitis symptoms that have not responded to standard bacteria-focused therapies. So then we have to use the other things, including all the other lifestyle changes that we recommend for people. Integrative approach to refractory chronic prostatitis. So 30-year-old male has been suffering from persistent pelvic pain, urinary frequency, and non-bacterial prostatitis diagnosed as CPPS. He has tried multiple medications, including alpha blockers, antibiotics, without significant relief. Detail, so given the refractory nature, again, this may be due to our friend, the bad guy. Chronic prostatitis and benign prostatic hypertrophy. That's a big one. So what causes BPH? Does anybody know? What is the #1 reason why men have BPH?
It used to be thought that it was from high testosterone, but that's not the case. That's been proven. It's not. I think it's from a lack of iodine from my research.
Actually, I think it's too much estrogen.
Right. And iodine is also aromatase inhibitor.
Right.
They can work together. Yeah, it's estrone, as Dr. Halassa will tell you. It's too much estrone.
Yeah. So when we give testosterone injections or testosterone gels to people, what should we be worried about?
The conversion to estrone.
The conversion to estrone. Unfortunately, when you look at many people who give testosterone supplementation, but don't test the estrogens. They don't test estradiol, they don't test estrone sulfate or estrone, or to try to figure it out. I really think it's important. If a man is going to get testosterone, we need to test those estrogen. But also, above all, we have discussed that before with Dr. Halassa or Dr. Clearfield, that we need to do an aromatase inhibitor. So what are your favorite aromatase inhibitors that you use when you give testosterone?
I use iodine. I don't like anastrozole. I use that very rarely.
Okay.
Progesterone will be 1 and DEM will be 2nd.
Okay, so we use progesterone. We use some people do Arimidex or anastrozole, but yes, go ahead, Doctor.
I think you do want good estradiol levels because it's important for the bone in man. You just don't want estrone, and you get estrone from the conversion in the liver, so from oral testosterone.
Okay, so there is a question. The question is, which one is more potent for bone density, testosterone or estrogen?
Tough one. They're both critical.
But there are cases where men who were given testosterone supplementation, but aromatase inhibitors with it, and their estradiol levels were below a certain threshold of like 35, they had spontaneous hip fractures. And so begs the question whether estradiol by itself, independently from testosterone, is important for bone density in men.
Right. But estradiol also can predispose to cancer too, right? So there should be an optimal level, right?
I do think it's estrone and not so much estradiol, and it's
Yeah.
that conversion. And I think that's mostly because of the liver conversion with oral. At least it's like that in women. I don't know about men.
Yeah, so many people don't test the estrogen metabolites also. So like the 2-hydroxyestrone or the 16-alpha-hydroxyestrone, nobody's testing that. So they're just giving them all these supplementation without knowing exactly what is going on with this person. So definitely when you're going to give any testosterone, I really rather give them the upline, meaning progesterone and DHEA. Give them a testosterone inside. Even sometimes you can give them pregnenolone. So pregnenolone, DHEA, progesterone, they convert to testosterone, but you put an aromatase inhibitor, and some men can do actually fairly well, especially the young men. You don't want to kill the sperm production, or you don't want to kill their manhood. You really don't want to give them any hardcore testosterone. You want to give them the upline, put an aromatase inhibitor, and they can make their own testosterone. The older men who cannot produce testosterone differently, you give them supplementation, but you have to block it so then they don't get into all that. But I rather not give them, I don't give them any estrogen a lot, because for me, if, as you know, from what I have done, I'm estrogen phobic. Why? Because the environment is littered with estrogens. The majority of the chemicals we find in the environment are estrogenic. So if you give any estrogen at all, you have to be wary when the side effects start surfacing, because they may be potentiating the existing estrogen in this person. So that's why yes.
Yeah. Yes, Doug, I think we have to differentiate between the alpha and beta receptors in estradiol and whether the endocrine disruptors type of estrogens, which are xenoestrogens, are very different than estradiol itself. Estradiol itself is important for men for both cardiovascular health and bone. We're figuring out more and more. And to put it in the same as, the xenoestrogens, I think is unfair towards estradiol, because we are figuring out more and more how beneficial it can be.
Yeah. So when you give testosterone without opposing it, sometimes it goes to estradiol too. So people get some estradiol out of that. And many people think it's a gas estrone, but remember, in the body, the estrone and the estradiol interconvert.
Yes, they do. But there is something about the oral form through the liver, which converts more into estrone. Basically, you have less of the
oral
reversal.
form, yeah, definitely. And I don't ever give anything oral. I do topical ones. I have been doing this since 2007, and it has been really great, giving topical hormone replacement, whether it's progesterone, DHEA, or DHEA, we give them orally, but we can do it topically as well. Testosterone topically works really nice. Case 7, prostatitis following instrumentation. That is another big one. So when we send people to urologists, what do? They will do a cystoscopy, they will do all of these catheterization. If we do that differently, we're going to have some prostatitis that will surface, and many times it could be bacterial, could be fungal, could be all of those things. So we have to worry about that when we see patients with those. Immunocompromised patient HIV patients, they have more of the fungal prostatitis, so you have to be aware of this as well. Prostatitis concurrent with erectile dysfunction, that is a most common theme. Many people who have prostate inflammation, prostate enlargement, prostate anything, they have erectile dysfunction that goes along with it. So when you're going to give them all these supplements and stuff to try to help them out, you have to think through this carefully. One of the, when we give finasteride, how many of you know one of the major side effects of finasteride?
They can get a loss of erection.
They can get a loss of erection, right? They call it PFS.
Post-finasteride syndrome. Yeah.
Post-finasteride syndrome, meaning you give them, some people even they take Propecia for hair growth because they think the hair loss is due to too much DHT. And they're doing the Propecia, and all of a sudden they have no erections. The young people, I have a couple of patients like that who, for years, they were on Propecia, and all of a sudden they lost their erection. They went from doctor to doctor, and nobody can figure it out. They have post-finasteride syndrome. So personally, I don't give that medication to anybody. I want to make sure that nobody loses their erections. It's very important to notice that. So they talk about alpha blockers, so you have to really know all of the other things that can come with it.
Isn't it true that finasteride is a very long-acting drug, and you can you can get away with as little as one pill every 5 days or so, or
perhaps
a week? And at those doses, do you still see the problems with erectile dysfunction?
That I have not tried, so I don't know. But most doctors who give finasteride, they don't just give it. Go ahead.
Yeah, I have a whole lecture on this if you're all interested.
I don't think we need finasteride. Progesterone itself doing works like finasteride. And evidence of that, you can use progesterone for hair loss, androgenic hair loss, and it does same like finasteride and better.
That's correct. Actually, I know of that. Yes, progesterone blocks the conversion of a testosterone to DHT. So in essence, it's a good. It could be a good alternative to finasteride. But people who don't know, who do not have a training, they may go with the finasteride. Like the general practitioners who don't know any of this, they will go with finasteride because that's what they will learn in school.
Get the syndrome.
Well, if you hear Dr. Williams' lecture about finasteride, you will never touch it.
Yeah, that's I know that. For me, I'd never ever touch finasteride. I would never prescribe that medication to anybody. But I'm just saying, people who don't know, they may go for it, but that's not a good drug.
All right.
So I have some multiple choice questions. So case scenario, 50-year-old.
Dr. William, I think the company who are making finasteride, they're not happy with you.
Just tell them to get in line. Just tell them to get in line. It seems to be a universal theme.
Yeah. So Dr. Bill, if you're doing finasteride lectures, then you have to watch out for all the people around.
Yeah, I did it about 2 years ago for AMMG, actually. So, but if you want, I can do it again.
50-year-old male.
It's a lot more complicated than just erectile dysfunction.
Yes, it's a lot more.
There's a lot of psychiatric issues that can happen with it, and it can happen with just one dose. So, and sometimes it'll happen after patients stop taking it. So it's pretty it's a phenomenon. So, okay, multiple choice.
Question before we go to the multiple choice. You have the answer, so it's easy. So case scenario, 50-year-old male presents with fever, chills, painful urination, and pelvic pain, has a tender swollen prostate on digital rectal exam. Urine culture is positive for E. coli. Most likely diagnosis, easy. Acute bacterial prostatitis. So how are you going to treat it? What is the best treatment for E. coli related prostatitis?
Metronidazole, right?
Probably not, because that would not be the first line.
Vancomycin, it's very hard.
That would be too much. You don't want it. So a basic acute bacterial prostatitis, E. coli related.
Bactrim will work typically.
Bactrim will work. Liver queen will work. The one that you don't want to do is Cipro, because now we find that E. coli can be resistant to Cipro. So you have to be very careful when you pick your antibiotic.
They have other problems associated with them. I don't use the fluoroquinolones.
Yeah. So what is the major problem with the fluoroquinolones?
They cause a collagen disintegration.
Right, so your tendons may not be worked, so you can have sore tendons, or even you can easily break your tendons.
Aorta too. I have a guy, his aorta crumbled.
Yeah, that's one of the major problems with the fluoroquinolones. Scenario: 35-year-old male has been experiencing chronic pelvic urinary urgency and pain after ejaculation for more than 6 months. Urine culture and PSA are normal. So what do they have? The CPPS without finding, because you know there are two kinds, right? One with bacteria and one with no bacteria. So that's what this is. 60-year-old male with diabetes presents with recurrent urinary tract infection, pelvic discomfort, and a mildly elevated PSA level. His symptoms have persisted despite several courses of antibiotics. So what are we thinking?
Fungal.
Fungal. So the treatment will be antifungal. So what would be the best antifungal to use?
Diflucan.
Fluconazole first. And if it's not responding, then you can go down the stream. But for now, fluconazole will be best. 45-year-old male complains of dysuria, lower back pain, and intermittent hematuria. Has a history of benign prostatic hypertrophy and recent bladder catheterization. So what do you do? Broad spectrum antibiotics, and we talked about that, what antibiotics to use. 30-year-old male being evaluated for infertility. During his, so when you see the first sentence, what are you thinking of right away?
Chlamydia.
Chlamydia, a symptomatic inflammatory prostatitis, and that could be chlamydia related. 67-year-old male with a history of chronic bacterial prostatitis presents with increasing lower urinary tract infection and PSA level that has progressively risen to from 4 to 8, actually, over the past year. Symptoms have persisted despite adequate antibiotic therapy. What is the most appropriate next step? So if you have a high PSA, you're not quite sure what it could be, you have to get what type of diagnostic thing? Big gun. Do the MRI. What type of MRI are we doing?
Contrast MRI?
Multi-parametric.
The multi-parametric MRI. That's what we should be doing. 55-year-old male has been treated for chronic bacterial prostatitis with multiple antibiotic courses over the last 3 years. Presents with chronic pelvic pain, recurrent recent onset of generalized fatigue, and weight loss. What should we be doing?
Cancer evaluation.
We have to do cancer evaluation. We have to check all the stuff, markers, everything. 52-year-old male with a significant medical history presents with lower urinary tract symptoms, decreased stream, nocturia, sensation of incomplete bladder emptying. PSA is elevated at 6. What should we be doing? We have to find out what it is, right? Prostate ultrasound and possible biopsy. Should we go for biopsy, or can we just do MPMRI? What would you do?
MPMRI.
MPMRI. I would not do biopsy, because why shouldn't we do biopsy? Because what is the rate of diagnosis for biopsy? What did we say? Actually, not a whole lot, 43% you get. And it's not, sometimes it's not, it causes more problem than it's worth. So perhaps we should not do the biopsy at all. And case scenario, 59-year-old been dealing with intermittent pelvic pain and frequent urination, has history of type 2 diabetes, and was recently treated for urinary tract infection. What are we thinking of? Every time you see diabetes, they have sugar. When you think of sugar,
fungus.
So that's the end of the presentation. If I would entertain any questions or anything or discussions, or everybody can chime in now.
Let's see what's in the chat.
Oh, there's a lot.
Well, let's see. Something about copper added with using high levels of zinc supplement.
So I personally, copper, if it's too much, it promotes estrogen. So I personally would like to do the zinc, because zinc is an aromatase inhibitor. So I personally use a lot of zinc, but I have some products that are copper related, some supplements that have copper in them. I'm a little bit more leery about those because of the estrogenic effect.
Okay. So Stephen H has a ratio of 15:1 of zinc to copper. That's what he mentions anyway.
Okay.
Okay. Someone asked about chlorine dioxide.
Yeah, so the chlorine is the same, it's a halogen. So the chlorine definitely displaces iodine. If iodine is good for prostate, for thyroid, for all of those things, then exposure to chlorine products may not be a good idea. So I personally tell people to stay away from it as much as possible. Unfortunately, the swimming pools and everything else has chlorine in it.
Yeah, Dr. Smith mentions that gentamicin IM works for MRSA.
Gentamicin is not one of the major use for MRSA. I don't know if people use it, but
it might be an add-on or
it could be adjuvant, but it's not the primary.
Something else to use.
Yes, vancomycin and linezolid.
Okay. There was a mention of a brand here for using so I won't mention that because we're still on the CME.
Right.
Looking for microbes. Okay. Is pounded African yams okay to get, or do you need the actual tubers?
You do, the pounded one is exactly the same, but I rather use the actual one. It's actually very nice, and it tastes, I mean, if you cook it right, they have so many recipes on YouTube. You can find a nice recipe and make a very nice dish with the African yam.
Dr. Hartman again, with iodines found to inhibit carcinogenic process in breast and prostate cell lines, consistent with findings showing that the incidence of prostate, endometrium, ovarian, and breast cancer is lower in populations with high iodine intake.
Okay. Yes.
And that article noted that the Republic of Ireland that you mentioned has the highest cancer incidence in Europe.
Because of lack of iodine.
Lack of iodine. Yeah.
Okay. Okay, that's all the chat. Anybody else have any questions? Well, Dr. Tano, all-star performance as always. And we cannot thank you enough. And I'm getting lots of kudos here for you, and make sure that we keep you on a short leash and have you back soon. So
thank you very much.
Thank you.